Welcome back to the Death and Grief Talk podcast. My name is Joelle Simone Anthony. I'm also known as the Grave Woman. And today I am honored to have a person that I have a lot of respect for, a fellow board member with the Compassion and Choices board, and just someone that's really becoming a friend, Dr. Satheesh Gunjana. Did I pronounce that correctly, Satheesh?
Nope, not quite actually. It's
Not
Satheesh,
quite.
Gunaga.
Gunaga. I
Oh,
apologize.
it's okay, Joel. We're gonna have a lot of time to practice that. So
Yes. Satish is an emergency medicine physician in Metropolitan Detroit. His primary roles are as the medical director of the emergency department at Henry Ford Health Center, Brownstown, which is a freestanding emergency department. He is also the vice chair of emergency medicine and the emergency department research director at Henry Ford Wyandotte
nope, it's
Hospital.
actually it's a Henry Ford Wyandotte Hospital.
Henry Ford Wyandotte Hospital.
Mhm.
Awesome. Thank you. He is also, as I mentioned before, a board member of Compassion and Choices. He is a husband and father of 3 young boys. Satish, please introduce yourself and let me know a little bit about what it is that you do, where you're from, your culture, your upbringing, and anything else you feel comfortable sharing.
Yeah, absolutely, Joel. But first and foremost, let me just thank you for inviting me to come on to your podcast and talk with you. It means a lot to me, and your friendship as well. As we get to know each other, also means a lot to me, and I admire you and everything that you do. And so, thank you.
Thank you.
Well, Joel, you gave me a great intro. My name is Satheesh Gunaga, and as you described, my primary occupation is as a emergency medicine physician, and I'm practicing emergency medicine in the greater Detroit area, what we often describe as the downriver Detroit area in Wyandotte and Brownstown. I actually work for a company called Envision Health, and it's through an Envision Health that I then staff the emergency departments within the Henry Ford Health System.
Mm.
So a little bit more just about me. I am a first generation Indian American. I was born here in the United States in Ann Arbor, Michigan, after my parents had immigrated from southern India in the early 70s. My father was a PhD candidate, and he had the opportunity to come to the US in the early 70s to do his postdoc at the University of Michigan. And from that point on, my family has been based here out of the United States. I actually grew up in East Lansing, Michigan. So that's the other university, big university in the state of Michigan at Michigan State. And honestly, it was really one of my life's honor to grow up in that city. In what I believe, a lot of university towns, extremely diverse, very multicultural, very expansive. And it was just a great honor to grow up there. I'm an only child, but I'm part of a much larger family. I have wonderful aunties and uncles and cousins, and was raised by grandparents, and have a lot of family involved in my life, both growing up and now. And then, as you described, I think the heart of who I am today is primarily as a father, 3 boys, as a husband, and as a son. So hopefully that's the description you were looking for.
It is, Satish. And I have to tell you, one of the things that stood out to me when meeting you in person is just how down to earth you are and the passion that you not only have for medicine, but for connecting with people on a deeper level. How long have you been a physician?
Yeah, I graduated medical school in 2005 from Michigan State College of Osteopathic Medicine. And so I've been practicing medicine for 18 years. But even after you finish medical school, Joelle, you go on to do specialized training. And when I did specialty training in emergency medicine, that was 4 years. And so I've been practicing as a board certified emergency physician for about 13, 14 years. And then, but, really as a physician since, August of 2005, so almost 18 years now.
Wow, that's a really long time to be caring for others. And we'll get into a little bit more about that in a little bit. But because I know you personally,
Yeah.
I'm aware that beyond being a physician and beyond caring for others in such a compassionate way, your gift and specialty is in delivering end of life diagnosis and conversations with families. And if you don't mind, can you walk me through what one of those conversations may look like and how you identified that this was something that you were good at?
Yeah, absolutely. As an emergency medicine physician, part of my specialty is that I need to be prepared for anything, anywhere, any day. What an average emergency department shift looks like really varies from day to day. Obviously, the emergency department is available 24 hours, 7 days a week, and we often will get some of the most acute and critical illnesses that come through the ED. Excuse me. So by necessity, I need to be skilled at both resuscitation and trying to bring people back from the verge of death. But sadly, there are some people that we just cannot change their course. And so we're often giving really bad news to family members, patients even, about prognoses and so on. So in the emergency department, though, we often find a group of patients that are coming to us critically ill, like literally on the verge of death. And maybe even on the verge of death that I can temporarily delay, but that is ultimately, what I would say inevitable. That even where we are in medicine in 2022, I can't bring you back to life or even a meaningful life, but I can keep you alive for a while. And what I have found is that over the course of my career, that if you really sit down with a family who has a family member who is in this type of situation, essentially what feels like a futile, inevitable death, and you really explain to them what's happening, and you really start to explore how their loved one would both want to live and how they would want to die, you'll find that families are very thankful that we engage in that type of goals of care conversation, and then will allow me to help them guide the course that is best for their family member. So and that might be, nope, I want everything done, let's keep going to the ICU. And then in the emergency department as our team, we say absolutely, we'll do everything. Or it may say, hey, look, my father would never want this care, he would not want to be on a ventilator, he would not want to be on these medications. And then I can actually, withdraw that care, make them comfortable, make it possible for families to be next to their loved ones, holding their hands, helping them through that transition death process. And so that's a conversation that I'm always been willing to embrace. And then over time have become, a good navigator for families for that conversation. So
I heard you mention the verge of death, right?
yeah.
And I think that in our society, we use terms like near death experience and we use phrases like, I almost died. Like you hear people tell stories, and I'm guilty of it too. Like, I almost died doing this. What, in your professional opinion, is the verge of death? What does that look like? And what is happening in the body when that's taking place?
That's a great question, Joelle, because you're right. Anecdotally, we might use these terms, but in the capacity that I'm describing it as a physician, as an emergency medicine physician, it's essentially what I would describe as multi-organ dysfunction syndrome, or MODS. Essentially, that there has been some type of insult to an individual, whether that be infectious, traumatic, stroke, massive heart attack, some type of acute event has occurred, that from that event downstream, organ by organ start to fail, multi-organ dysfunction syndrome. So though it may start initially as a heart attack, the heart pumps blood to the brain, to the kidneys, to the liver. And as the heart fails, the kidneys fail, the liver fail, organs start to fail. You start to see shock, this inability to maintain your blood pressure or perfuse your organs. And in that capacity, I call that essentially, verge of death or near death. Often, even in my practice, I will see people who have died who have actually stopped breathing, whose heart has stopped beating. And because of really great pre-hospital EMS care or really great ED care from CPR and defibrillations, will bring someone back. But immediately, they actually have crossed, the gateway there. They actually were dead that we brought back, in capacity. But those are the terms that I typically am referring to it as, Joelle. Does that answer your question?
It answers my question very well. So were these conversations with families in that bedside manner with families and even maybe the person that's passing away? Was that something that you learned how to do in medical school? Was there training on these types of conversations? And how long did it take you to get comfortable? I can imagine the first time having a conversation like this with a family must have been traumatic for you as well.
Yeah, absolutely. And so it continues to be traumatic, unfortunately. I think as human beings and as healthcare professionals, we truly only have so much capacity for death and these traumatic moments. So, but we'll talk about that more over the course of this discussion. I think the question I heard you ask me first was, when did I start to get trained to handle these type of conversations and encounters? And did I have formal training during medical school? And actually the answer is, it started during medical school. I did receive some formal training, but really the education occurred firsthand as a resident. And that first 4 years of specialty training outside of residency, this is where I really learned the trait. The amount of formalized education that I received around giving bad news, goals of care conversations, advanced care directives, in my opinion, was minimal. And not as in any disrespect to the training I received or the people that trained me, but that at least in that time, in the early 2000s, this was not something that was emphasized within our curriculum. It was discussed. And so how did I learn it, Joelle? I learned it in the intensive care units at Henry Ford Detroit Hospital, which is a large 1,000-bed tertiary quaternary facility. And I spent a lot of time as a resident working in the surgical intensive care unit and medical intensive care unit there. And essentially, sadly, the ICUs are where a lot of death occurs. Maybe even a lot of what we call goal discordant care occurs, care that people never wanted, ventilators, blood transfusions, surgeries that they really didn't want, that accidentally occurs because maybe these conversations don't happen soon enough. But that is where my exposure came. And then I don't know if I ever am comfortable with this situation, but there's something about me as an emergency medicine physician. I think this is common for a lot of people within emergency medicine. Like when the bell is rung, you just step up. And so there's some adrenaline that occurs, some reality that I got to turn this on and be ready to have this conversation. And I do. And I think even within our own specialty, we have to compartmentalize this work. You can only see so many dead children or tell so many people that their loved one is dying or died. And if you keep taking that home with you, it'll break us. So, I've learned to give you everything I got when I'm at work. You'll get everything I got. But when my shift ends, I just have to put it all behind me and just, pretend like it never happened in some ways. Otherwise, I don't know how to exist,
I can definitely relate to what you're saying about compartmentalizing as a funeral director, because if I took it home, I'd go crazy, as you said.
Agreed.
But what do you do to care for yourself? You've had this day, you've had to deliver this bad news, perhaps about a child, perhaps in a situation that reminds you of something that hits close to home. How do you care for yourself, and how do these losses impact you mentally, spiritually, emotionally, and even physically? Because I believe we can psychosomatically hold responses in our body.
You're absolutely right, Joelle. And I don't know if I have I think I can give you context to what I do. And then hopefully that will give context to what other medical professionals do. And I bet if you ask this question to 10 different medical professionals, they would all have different answers on how they cope But this really ends up becoming a coping skill, a skill of resilience. And so what do I do? Well, the one, I've been doing it for a while. And I think with that starts to become some process that allows me and my body and my mind to compartmentalize these incidents and separate myself from it. In the moment, I really feel like if I am there in the moment and I give you everything I got, and I'm patient and I'm listening and I'm not argumentative or trying to make my own agenda, if I'm just really there for you and your families in that moment, I feel like when I do go home, I'm proud of that moment that I was involved in it. And at least say, hey, I did what I could. Recognizing one, medicine is very imperfect. It is not black or white. It's very gray. So even as a healthcare, as a physician, sometimes I sense and other people sense like we failed you. We failed your family member. They died on my watch. And so part of this is that I need to know that I'm prepared to come into work and that I'm giving you everything. And if I can go home saying that I tried my very best and I gave you everything I got, then I can feel like I don't feel as much of a scar from the incident. But I think if I had to draw this up, it's scars, Joel, is what happens to us as clinicians, or anyone that lives in this realm of end of life and postmortem care and so on. But just over days, over months, over years, you are involved in this work, and you just start to develop scars. You don't even realize that you're carrying them. There are patients and situations that I'll never forget. And a little 3-year-old boy who was sleeping in his bed was shot, on with stray bullet, came in with a gunshot wound to his brain. I'll never forget his face or that moment or those moments that occurred when we tried to save his life. Even years earlier than that, there's a young little girl in a hotel lobby that her parents, she stopped breathing, and I remember working her as a paramedic, because before I was an emergency room physician, I was a paramedic. I did the 911, in Washington County around the Ann Arbor area. But I'll never forget her face or that moment or what I felt in that moment. And I don't think they're ghosts that haunt me, but I'll tell you, those 2 patients, along with hundreds, they're just part of me now. I'll never forget their face. I'll never forget the moment I told somebody, oh my God, you came in with a cough. I ordered this chest x-ray. Now you have metastatic cancer, right? These incidental findings, but these moments, they just live with me, but they don't haunt me. But they are a part of me, and I need to figure out ways in which to manage that emotionally. Some days I do it better than others. And then very sadly, Joel, in my own profession, there is a very high burnout rate. Even just the physician as a profession has one of the highest suicide rates of any profession out there. As a community of healthcare professionals, as a college, the American Medical Association, the American Osteopathic Association, they have re-emphasized healthcare professional wellness, and trying to figure out new tools to help us stay stronger. But I think I said a lot of different things there, but hopefully I answered your question on kind of what its impact has been on me.
You did. And it kind of makes me, this was like the wild card question, but I feel like this is really an appropriate place to segue into it. I can imagine that, the saying they have in medicine that the closer to the brain you get, the more of a God complex the physician has. I've heard that said amongst fellows that I've worked with in both neonatology and in cancer. And my question to you is, do you feel not necessarily like you are God, but that you're put in that position, at least in the perception of the families or those that come into the ER department or the emergency department? Like they're looking at you as the person that holds the key to life.
Yes, absolutely. And I'm hesitant to use God complex or make a religious analogy to this. But there is no doubt. Well, and by the way, too, religiously, I'm unaffiliated with any religion, but I'm extremely spiritual. I have spiritual beliefs. I encompass my things from different religions. But I would agree with you in this moment, in this medical world of giving bad news and delivering bad news, and goals of care conversations. The physicians, we hold all the power initially in this discussion. We have the power to update the families on what our understanding of the illness and disease trajectory will be. We have the ability to be engaged and offer multiple different options of care. And then we have the necessity to actually just sit down and listen and try to get a feel from the patients and their families what their wishes are. So in that capacity, I feel extremely empowered, and and the patients and their families, they are counting on me and all of my team to help them make the right decision, or do everything possible to keep their loved one alive or give them the best chance for survival or good outcome. So in that capacity, yes, I've been given a great honor that I could even be in this position to make this impact in people. And there's definitely a power dynamic that exists. And what I'm proud of is that the dynamic of medicine that I hope that I'm practicing is very patient centered and patient oriented. Whereas there was a world of medicine that existed 20, 30 years ago that was very physician centered. Let me tell you what we're going to do, and then you're going to do it.
Right.
A world of a shared decision making, which is where information is you can process, and I try to give you options, and we try to make the decision together. Hopefully representing the best wishes of the patient and their vision of death or our life.
And I think that's another thing that kind of connects us, particularly through the Compassion and Choices board, is that we both truly believe, whether it be on the healthcare side or the death care side, that the focus be patient or person focused, not necessarily what the societal medical or death care standard is. And I thank you for that, because I unfortunately have lost a loved one in a hospital setting who had a stroke. Medication that should have been available was not available at that hospital. And we were basically told that if my grandfather did not have a DNR in place, he would have suffered unnecessarily. So, yeah. So next question. You kind of touched on.
I'm sorry that was your experience with your grandfather, and but it also sounds, sorry.
No, it's fine. I appreciate that. Does your work at any time conflict with any of your personal beliefs? And what I mean by that specifically, have you ever encountered a family or a situation, a patient who you knew, if something minor maybe, or something that was able to change was changed, their outcome would be different? And did that bother you or conflict with something that you believed personally, or the opposite?
Yeah, so that's a broad question, actually. So let me answer it maybe in a couple different ways, a couple different buckets. Yes, there are definitely moments within my own daily work of incidences and behaviors that are performed by me and my staff that I'm not proud of. Okay. And it's not because we're being malignant or belligerent, or, it's because, again, the forces that drive healthcare. And I'll give you my best example. I am a nocturnist as well. So when I practice emergency medicine, I work just the night shifts. All right.
Okay.
And that was a choice that I made many, many years ago and have continued. That's who I am. But something about being a nocturnist in the emergency department is I encounter a lot of homeless individuals who often have other, polypharmacy and substance abuse co-disorders. So
Okay.
often they're intoxicated, they come in, it's obvious that they're homeless. And we take care of them. We bring them in. We make sure that there's no acute medical emergency. Sometimes we start IVs and do labs. Sometimes they don't need that. We feed them, these patients, and we let them sleep in our emergency department. But my shift ends at 7 a.m. And I can't let people sleep in my department all night long into the day. And even in the culture of emergency medicine, we're not in the habit of trying to sign these cases out. So very personally, right? Because it's still the right thing, it's the right process. But around 6 a.m., I'm waking up 2 or 3 or 4 homeless individuals and telling them, hey, time to go, got to get moving, got to get going. Here's another sandwich, here's a drink, here's some socks, here's a blanket. And I live in Michigan, Joelle, and it is cold and there's 2 feet of snow outside. And then even individuals in this capacity are saying, I can't leave. And, they might try to throw a new card, like now I'm suicidal or, oh, now I'm having chest pain. But then all of a sudden, all of the care that, it feels like we both are kind of pushing the extremes here of the situation, but it doesn't make me feel good, right? I didn't go into medicine, an emergency medicine specifically, to be like sending people out into, 0-degree weather, even after I've let them sleep in my ear. So that's one example. Number 2, Joelle, is we make mistakes. We just make mistakes. Like I said, medicine is not black or white. It's very gray. We get tricked by, the data. Some stuff is very obvious. Some stuff is not very obvious. We have communication errors and electronic medical record errors. And so sadly, I've been a part of a lot of errors. And those will haunt any clinician as well. Not only in terms of what my mistake impact was on this patient and their outcome, but then even how I take that home and beat myself up over it. And then how we sit in medicine with anxiety that I'm going to get sued over that. There's all these components that kind of, play in the background. But yeah, did that answer your question? Did that address the question?
Yes, very, very specifically. Yeah. Has there ever been a time where you questioned your role or your work and just felt like, you know what, I just can't do this anymore. I need to find something else?
Yeah, sadly, that is the case. So, and I'm nervous. So I've spent, again, part of my story is that I'm a teacher by nature. I'm an educator. I spent the first decade after I graduated residency as the associate residency director for my emergency medicine residency at Henry Ford Wyandotte Hospital. So I'm training the next generation of emergency medicine physicians, and I love teaching. Thank you. And so that being said, there's just no doubt that over the first decade of my emergency medicine career, I was like I just felt like I was a stone that was like kind of like hitting another stone over and over again, kind of getting worn down. Emergency medicine in general is a very rough specialty. And it did start to wear on me, and I did start to experience burnout, and I did start to experience dissatisfaction with my work. And then my work started causing me some anxiety. And then even in my own mind, I'm looking out there like, what's next? How can I? And so honestly, Joelle, about 4 years ago, there was an opportunity for me to make a transition into administrative emergency medicine. And one of the biggest determinants for me to make that move was it allowed me to work less clinically. So normally I would work 16 clinical emergency medicine shifts a month. This let me cut it in half to 8. And it was important to me because I'd never want to stop practicing emergency medicine, but I did need some separation from the wear and tear of critical illness and, the wear and tear of the ED. But then I found myself on the other side on this administrator end, which I would often describe myself as a middle manager. I answer to everyone below me who are is my team, but I answer to everyone above me who are really my directors and the bosses. And then I found my own issues with wellness in that world. So I guess that was a long way of me saying yes. Over the course of my career, I have questioned whether this was sustainable or whether this was healthy for me. In this moment, I keep developing tools to be stronger and stronger. But I am very guarded and I am very nervous for what I thought would be a 30-year of career in the trenches. I don't know if I can do that, but I'm going to make my impact as a physician in other ways. Whether I'm taking care of patients in the ED or whether I'm working with you, trying to push a national organization like Compassion and Choices to advocate for, all Americans and their end of life options and choices. This is going to be the work that I'm going to engage myself in one way or the other. So
I can totally relate to that, Satheesh, because during COVID, I found myself being burnt out in a way I never had before in the funeral home. And I was shifting anyway. I had just started teaching, and it was like, you know what? As much as it hurts me to let the daily practice in the funeral home go, I found comfort in the fact that I'm impacting so many more people through education. And then Compassion and Choices showed up with this opportunity. So, like you, I'm very excited because now I'm doing it on a national level. Where had I remained in the funeral home, I'd only be, and not that it's any less important, but I would only be having an impact on my immediate community. So I totally can empathize with that pull in both directions, but the
absolutely.
level of freedom that comes with making the decision. And I so appreciate you for showing the humanity behind healthcare. That's another thing I truly admire about you is that
Thank you.
you're honest about your struggles. And I feel like anyone that's listening to this in any line of work, particularly the medical community, will find solace in knowing that they're not alone in that emotional aspect. A lot of times as professionals, we feel like, well, this is my job. I don't get to feel this way. I chose this, but we're human at the end of the day. So thank you for showing the humanity.
You're
Are,
welcome.
are there any particular cases, being a husband and especially a father of 3 young boys, are there any particular cases that are just particularly difficult for you?
Yeah, look, pediatric deaths and pediatric, critical illness is so difficult. I don't think we're designed well to see dead children in our hands or feel the futility in your own skills to know that you can't bring them home. That little black boy who I told you got shot in the head, sleeping in his bed. He was 3.5 years old, and my middle son Asher was right around 3.5 years old, and like I could just see Asher. Right, I mean, they were the same age, and I just went home. I raced home that day. Cuddled my little boy, and just felt so grateful that that wasn't me in that moment. I wasn't that other parent that had to deal with that. I lost my father about 1.5 years ago to COVID. And so I'm uniquely emotional these days. Well, one, I'm just even emotionally challenged compared to I was pre-COVID. So, I joke around with people about like my emotional fortitude is a fraction of what it used to be. Like I could watch like an episode of like we watched Mulan not too long ago, and then midway through I'm bawling through Mulan, and my kids are looking at me like, "What are you doing, Dad?" But, but nonetheless, yes, children is something that's very difficult for me when I'm encountering patients that are like me or were like us, immigrant families or families of different ethnicities dealing with an elderly loved one who is dying of COVID or of something, have, challenges, connecting with the healthcare, system because culturally our communication is different. And I recognize that because I saw it firsthand in my own Indian American family. So those are cases that I find that are uniquely more challenging or hit me closer to home. Yeah.
So last question. Well, actually, I have 2 more questions.
Please.
So the first one is going to be more about those that you serve, and that may be like those that you serve. For anyone who's watching or listening that may have lost a loved one or given a terminal prognosis or diagnosis from someone like you in an emergency room setting, who are having a hard time processing the reality of their loss, what words of comfort would you offer?
I don't know if I have those words, Joelle, very honestly. Um, what I would say is if you are a loved one who has another loved one who is suffering or dying, be their advocate, be their voice. Ask the physicians and the care teams, what are our options? Do not feel like you're just given a couple choices and that's it and you have to move on. But be there. And then also know that in the healthcare setting, we are advocates for life and curative treatment, but we are also advocates for palliative care and comfort care. And the two of them don't need to be antagonistic with one another. You can get curative care and palliative care at the same time. So I would just challenge any viewer here of this podcast who has a loved one who is suffering from a terminal illness, or you end up becoming their advocate or decision maker. Have those discussions with your loved ones. Make sure you understand how they want to live, how they want to die, what their wishes are, and then just be a stalwart advocate for them. Because often there will come a time when your loved one can no longer vocalize or verbalize these decisions, and it will be your obligation to make sure that their wishes are honored. And if you can verbalize that to me as a physician, we will honor them. And we can make death more comfortable or more peaceful, or however that term may be. So
I appreciate, again, your vulnerability in saying that you don't have the words. I felt the same way when you expressed, and I looked at your face when you were talking about your father. I was like, I can't
yeah,
just say sorry, but my prayers are definitely with you, especially coming on the heels of Father's Day.
yeah.
I can't imagine,
Yesterday,
yeah, the
that was a
void
tough
that,
day. Yeah.
yeah. So my prayers are definitely with you.
Thanks, Joel.
That is amazingly proud of you.
Thank
I,
you. He
you're,
is. He is.
yeah.
I'm very proud of him too.
Yeah. So, Satheesh, last question. What's next?
Yeah, I'm glad that you asked that. Well, look, let me wipe away a couple tears here. Classically, the gray woman's got to make you cry on her podcast, right? Classic. So, what is next? So much is next. Obviously, from a personal standpoint, I just want to be present and be a good husband and a good father to my boys and a good son to my mother now. And so, I'm really trying to reheal and recenter around my family. But yet, nonetheless, I am still have large obligations to my emergency departments and my teams, and so I'm trying to find balance between work and life. And slowly but surely, I've been finding that. Research is very much a passion of mine, and so I continue to explore larger and larger and more impactful studies and trials. But without doubt, the area of my life that I'm most passionate now is this journey around emergency medicine and palliative care.
Mm-hmm.
Kind of this topic that you and I have been talking about. You don't think of the emergency department as the place where you go get palliative care. But what I think I want your viewership or the world to understand is that patients who are critically ill or who have terminal illnesses will present to the emergency department in their last days and months of life. And so the fact that I need to be prepared to handle any medical emergency, it also means that my profession needs to be able to provide the most amount of education and primary palliative care resources to patients who may want that in the ED. And so becoming a part of an organization like Compassionate Choices and being a part of that organization over the last year as part of the Healthcare Advisory Council, but moving forward with you and many others on the board of directors, I'm just so excited about advocating for early palliative care resources. Something I'm going to make a pitch here, or at least I'm going to I want to give a shout out, please. Compassionate Choices has a multi specialty collaborative that is called Medicine, the Emergency and Palliative Medicine Initiative, National Initiative. And essentially, we're collecting a group of emergency medicine physicians, nurses, social workers, chaplains, people of all sorts of multidisciplinary backgrounds and experts in all sorts of different areas to start to explore how do we move palliative care resources up front in the emergency medicine setting. And we are not the first people to ever try to do this. There are great emergency medicine physician and palliative medicine leaders that have led us to this stage. And I'm just excited about being a part of an organization and this collaborative that is now going to continue to push that forward. And my hope is that they'll be training the next generation of doctors like me who want to embrace this conversation in the ED, that don't think they're too busy to have it, that can take the time to sit down and have this conversation and guide people. So that's kind of what's next.
Beautiful. And thank you. I will make sure that the links for that initiative are listed in the description box, which will be attached to both this podcast and this video. And for those who may not be familiar with the term palliative care, could you give a brief description of what palliative care entails?
Yeah, and so yeah, that definition is complex actually, but what palliative care typically refers to is care that is centered around comfort, both physical, emotional, spiritual, that is not necessarily definitive curative care. So, i.e., you're diagnosed with a metastatic stage 4 lung cancer. The curative care would be chemotherapy, radiation, surgery. But at the same time, you can get palliative care, which is the pain control, the nausea and symptom control, the spiritual and emotional resources you need to cope with this. And you can keep getting both of those cares simultaneously. They don't have to exist, but there may come a point when the chemo and the radiation can no longer affect you. It's causing more harm than benefit. And then at the same time, then we would augment the palliative. We would just work harder and harder to make you more comfortable. Make sure that all your end of life wishes are being addressed, potentially enroll you in hospice, in which you could then avoid hospitals and other resuscitation measures, and maybe be with your family and die at home, or under that type of hospice care. So that's that term, palliative.
Thank you so much for that explanation, Satheesh.
You're welcome.
Thank you so much for taking the time to speak with me today. You've given me an education, and I pray that everyone that has listened to this or watched this has seen both the human side of healthcare and has learned something that they didn't know, which I'm confident we all have. So
thank you, Joelle.
Is there anything else you'd like to share before we end?
No, just again, thank you so much for inviting me. I'm so excited about the two of our journey together over the next decade, as we, try to move this organization that we're both so proud of continually forward. And thank you.
Thank you, Satheesh. Well, thank you all so much for listening. Live life, love hard. We'll talk to you next time. Okay. 1 second. Thank you so much for listening. To learn more about our courses, workshops, and how you can support The Grave Woman, visit www.thegravwoman.com. And while you're there, be sure to sign up for our email list.